Oh, why does it say I'm muted by the host? Oh, well, no, I'm not. Okay. It's hard to believe we're at the beginning of another cycle again. So this is the start of another 8-week cycle, and we usually start with talking about patient engagement and harm reduction and abstinence-based philosophies of care. Uh, and so this is a very timely topic, at least for me, as I'm working with an internal program at UH on some philosophy of care issues. So it's been interesting. So, so I'll start with patient engagement. And so again, the people that you meet are going to be at various stages of change with regard to not only their opiate use, but with regards to medication and maybe their mental illness and things like that. And so interventions obviously are going to vary based on patient stage of change. And so what is listed on this slide, and I'm sure you have many wonderful examples of your own, are some of the things that you might hear patients say. Anywhere from, look, I'm only here because a judge made me be here, or I can take it or leave it, or buprenorphine is a crutch, versus, yes, I'm here, I surrender, and I'm ready to go in terms of treatment. So there's all kinds of different attitudes toward it. And what happened to me this week was a Tuesday. I was working with a patient that has been sober for over a year and working a job full time and doing great. And suddenly Tuesday, she's like, Dr. Chris, I want you to get me off of buprenorphine. and and she was just, I was like, what do you say to that? And so I wasn't gonna argue with her. I mean, I did try to make some attempts to say, look, I think the reason you're doing great and that you're not having any cravings and that you have a full-time job is partly, not all, but partly because you're on the buprenorphine. She's like, nope, I'm done. And I don't know. And so I was very curious about, did somebody in her life perhaps say something to her, or did she read something? I couldn't get a beat on it, but I did as she asked, and I'm slowly weaning her off 25%, every couple weeks, and I'm afraid for her. That's all I can say. I think she's like 25, and I'm just like, I just don't want to read about her in the paper, and it scares the living heck out of me. But that's where she was, and she just sort of woke up one day and said, I don't want to be on buprenorphine anymore. So that's tough. So again, that's also part of this whole discussion is patient choice, for fortunately or unfortunately. But these are some of the key questions that I go back to. And these are borrowed obviously heavily from motivational interviewing and patient-centered care and things like that. So things like, hey, what matters to you? What are your goals? How confident are you that you can do this? And what are you willing to do at this time if you're not willing to do X, Y, Z? And so, again, all these types of questions kind of come to the forefront when I'm working with people about what they want to do with their treatment. So harm reduction versus abstinence only. This is, at least in my mind, a continuum from A to Z, and there may be even more than 26 ways of being. And for those of you who haven't seen this presentation before, I usually have the people in the audience stick a letter into the chat box once they hear a little bit of the presentation to try to self-identify as what letter they think they are. So I usually use the A as the abstinence only end of the spectrum, and the Z as the harm reduction end of the spectrum. And hopefully by the end of the presentation, you can guess what letter I am as well. So this is a philosophy of care that, has implications in almost everything that you do in a program. The things that I like to pick on are things like what happens with unexpected drug screen results, what happens with attendance that may not be 100%, and what happens with other forms of non-compliance. I'm thinking about Dr. Goldman's patient about actually like cheeking meds and then trying to share it with somebody that's a little bit more than non-compliance. That seems like, straight up diversion. And how does that kind of affect the treatment plan? And so again, when you have a number of individuals that work in the same place, it's really important to have consensus on what your philosophy of care is. Otherwise, things will fall apart sort of from the inside out, which it's hard enough already to treat patients with addiction without having the people that are on your team with all different sort of philosophies of care that might seem to be at odds with each other. So here's a little tiny taste of it. There may be other ways or other distinctions that you have come up with, like that you've noticed in your work, like, oh, I see that in one agency this happens and in another agency that happens. And I wonder if it has to do with philosophies of care. So again, I invite you to think about different places that you've worked over the years and what the philosophy of care may have been. So I do think that in both a harm reduction and an abstinence only place, um, addiction can be seen in a medical model, like that addiction is a disease of the brain. I think more so in an abstinence only program, addiction is sometimes seen as willful bad behavior. So like the person is doing the stuff on purpose. And if they really wanted to, they could like literally control different parts of their behavior. And so sometimes what happens in an abstinence only stance is that the thought is that, yes, this is a brain disease, but it can only improve with abstinence, and it can only improve with 100% abstinence starting right this second, right? So, and I guess to me, that just isn't what I've seen in terms of what my patients go through. So I tend to look at people as, yeah, this is a person that is a sick person that's trying to get well over time, and abstinence is a long-term goal. And I don't necessarily expect that the only way to get well is, to commit to 100% abstinence today. What happens in terms of unexpected urine results, at least on the harm reduction side, is it's like, oh, it's a conversation. So, oh, and it might result in a different level of care, or at least a serious conversation about what's going on. In some more traditional abstinence only programs, a dirty urine either 1, 2, or 3 times, it was like a 3-strike program or something. Oh, well, you're going to get discharged because clearly you're not serious about treatment. And why don't you come back when you are serious about treatment? Which always kind of struck me as very odd, because you're discharging the person for showing you symptoms of the very disease that you're purporting to treat. So that always, even as a youngster physician, I was always like, well, that's kind of weird. Like you're clearly very, very sick with your illness if you're using drugs and alcohol while you're in treatment. And then the attitude was always, well, okay, goodbye, come back later. And it was like, all right, that's strange. So I never did understand that. And the other thing that happens is when a person is not following the treatment plan, quote unquote, which we sometimes call non-adherence or non-compliance, is the in a harm reduction program, you might get an increase of support, and the program might ask itself, what are we not doing that, or how are we not meeting this patient's needs currently, and what might we do differently to meet this patient's needs, which is different from an abstinence only type of program, which is like, well, we have this set of rules. If you break the rules, then we're going to move you on. You'll either get discharged, we're going to tell on you to your probation officer, you're going to go straight to jail and not collect $200. So, it's it to me, it always seemed more like a game, and you were trying to like win the game somehow and get to the end of the game. And it was like, oh, that's kind of, again, strange, because I don't necessarily see treatment as a game, you know. Um, and again, I think that it really is, and one of the hardest things that I think there is to teach, because I think people have attitudes that have been with them for a long time. I think it's hard to teach attitude, and it's hard to teach sort of some of these points of view, because I think a person comes to the job with that already. So again, I love this this quote that basically says, what you see depends on how you view the world. to most people, this is a picture of dirt, but to a farmer, it's potential. And I just love that because I think of my patients who, for most of their lives, or for a good portion of their lives, because of their addiction, because of their criminal justice background, because of maybe the neighborhood that they come from, are basically seen as dirt, and they get stepped on. And when I see a patient, I just see a person that has been suffering for quite some time, and they have a potential for recovery. So it's that type of thing that I think it's sometimes hard to teach other people. And so I try to teach by example and things like that, but I don't know that it's something you can listen to a Zoom lecture and then suddenly your attitude is different. No, your attitude is what you've been carrying around sort of in your head for many, many years. And that is difficult to change. So I also, this is usually the point at which I like to have some audience participation. So if I can get a person who likes to read and feels like reading, read case example 1, and then I'll get another volunteer to read case example 2, and then we can talk about it and wrap things up. That would be great, and still leaves us with plenty of time to talk about cases. So yes, if I could grab a reader, that would be awesome.
I can read.
Thank you.
DM is a 30-year-old sugar addict. He was arrested yesterday for sugar possession with the intent to traffic. He brought donuts to his job. He had 4 previous dirty blood tests with a HbA1c of greater than 10. If he has one more dirty blood test, he will be discharged from the clinic because he only treats sugar addicts who can keep their HbA1c less than 7. He will be sentenced to 90 days of intensive nutrition classes and have 4 random blood glucose checks weekly. He also needs to attend 3 Donut Anonymous meetings per week and get his sheet signed. If he overdoses on sugar again and goes into DKA, he will get charged with sugar possession. After he gets out of the ICU, he will go straight to jail for a 30-day stay. That will teach him to never eat sugar again.
Thank you. And then I need a reader for number 2. Thank you.
I'll do it, Chris.
Okay, thanks.
SUD is a 40-year-old woman with an opioid use disorder. She overdosed last night on heroin. She was admitted to the ICU and treated with grace and dignity until she fully recovered. She was not discharged until she met with a peer support worker and a counselor and saw a psych for depression and PTSD. Her buprenorphine prescription was filled, the prior authorization was done, and the nurse taught her family how to use a naloxone kit in case of another OD. She had a follow-up appointment with an addiction medicine specialist within 3 days of discharge. A visiting nurse checked on her daily for 1 week to assess her recovery status, medication compliance, and ensure rides to 12-step meetings and IOP. Her family was kept informed of the ongoing treatment plan and given information on family support groups.
Okay, thank you both for reading that. And again, as you can tell, example number 1 is a bit tongue in cheek, and example number 2 basically reminds me of how I see people with perhaps other diseases, like DKA and heart disease getting treated in the hospital. Although many of you have pointed out that, boy, Dr. Chris, we're nowhere near this, even with treating regular diseases. And I'm just like, oh boy, that means we just have a lot of work to do. But be that as it may, it's an exaggerated example just to make the point that the language that we use, and some of that attitudinal stuff certainly does come out in terms of like punishment and willfulness and things like that, and especially in example number 1. So it's all about how you spin it, right? So getting onto the topic of language, recently, probably about 3 or 4 years ago, Ohio, trying to fight stigma about addiction, came up with the Ohio Language First team, and they created multiple materials that I will show you some examples of. And again, there's a Native American gentleman named Don Coyhis who basically says this quote, which is one of my favorites. He says, "Words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed." And that's kind of what we do in society. It starts with the labeling, and we see that in what's been going on with the George Floyd situation. We just see that everywhere. And so what I have here for you is a picture of dandelions. And again, the way you look at these dandelions from above, they look absolutely gorgeous. And then if you see hundreds of these dandelions in your front yard, you just sort of get angry, and you want somebody to come in and kill them all. So it just depends on whether you call them, flowers or weeds. And so to most of us, dandelions are weeds. But to, like a 5-year-old, dandelions are these gorgeous flowers, and they bring them up to you and say, "Hey, Mom, look at this great flower I brought for you." So yeah, it's a difference in how you see things. So here's an example of some of the materials that have been created. This is sort of like the front and the back of some of the materials that you can download, where it talks about what are the words that you can use to help reduce stigma. So for example, one of the ones that they've been trying to use is this term that I like. It's right down here. It says person in long-term recovery. So, even perhaps instead of saying, I've had 12 years sober or something like that, you might think about saying like, "Oh yes, this is a person in long-term recovery." So it sort of takes away some of that AA language that's been used traditionally, and sort of sets like a more level playing field. It's interesting. So I've started to hear people using that term a little bit more often, but that's coming from a lot of like national committees and things like that. So that's one that I like, person in long-term recovery. So here's another example about what are some helpful words to use and how do you look at it. And in fact, right here, right in the middle, is Mr. Coyhis's statement about flowers and weeds. So that's where I sort of took that from. And then I always like to end this presentation with a little story by Tara Brock. And I'll just read this one for you guys. Imagine you're walking in the woods and you see a small dog sitting by a tree. As you approach it, it suddenly lunges at you, teeth bared. You're frightened and angry, but then you notice that one of its legs is caught in a trap. Immediately, your mood shifts from anger to concern. You see that the dog's aggression is coming from a place of vulnerability and pain. This applies to all of us. When we behave in hurtful ways, it is because we are caught in some kind of trap. The more we look through the eyes of wisdom at ourselves and one another, the more we cultivate a compassionate heart. And I just, this one really just got to me when I came across it about a year ago, and it's really true, because a lot of us get uh, you know verbally abused or worse by our patients, and while I understand that that's sort of awful and sort of off limits, and we should tell our patients, "Hey, we don't do that here." I mean, I get that. You got to set those limits for, respect and dignity for us as the providers. At the same time, I know that when they're coming to see us, a lot of our patients are there because they're at their lowest low and they're at the worst point in their lives. And so I do try to, as she says, cultivate compassion and realize that, yeah, this person's leg is caught in a trap and they're coming from a place of a lot of hurt. And that sometimes is why they lash out. Now, clearly, sometimes they lash out because of other reasons, but a lot of times they lash out because they're at a place of a lot of hurt. And so sometimes a little bit of compassion goes a long way. So I'll just leave you guys with that. Here's some other handouts that you'll see on our website. And I'll see you guys this afternoon to